What's up, everybody? Welcome. In this lesson, we're going to be going over acute respiratory distress syndrome, also known as ARDS or ARDS. We're going to be going through the causes of ARDS, the pathophysiology behind all this stuff. We're going to also talk about diagnosis and treatment, and also how to grade severity of ARDS according to Berlin criteria. So let's go ahead and get started with some patho, why don't we? So I'm going to really simplify this basically. So there is first off a cause, which we're going to talk about these causes. But essentially something's going to happen here that then causes there to be alveolar endothelial damage. And this alveolar endothelial damage is going to then trigger an inflammatory response, and this inflammatory cascade occurs. In short, then, there is going to be alveolar edema, which then causes refractory hypoxia. Which refractory hypoxia is essentially hypoxia despite them getting oxygen. So somebody with ARDS could be on 100% FiO2 and they're still going to be hypoxic. So the big thing that's going to help these patients is positive end expiratory pressure, also known as PEEP, which they need with which they get with mechanical ventilation. So let's start talking about some of these causes. So let's go. Causes of ARDS. One of the big ones is going to be pneumonia. Another one is going to be sepsis, which you can develop sepsis from pneumonia. Another will be aspiration, smoke inhalation, another one can be trauma. Another one could be transfusion related. So this would be TRALI, transfusion related acute lung injury. And another one is going to be pancreatitis. The big one right now is COVID-19. COVID-19 causes ARDS. Okay, so those are some causes of ARDS. That's not all of them, but those are the really big ones that I would say that you should know that could cause it. And the pancreatitis, a lot of people don't know that it can cause ARDS. So when these patients come in with acute pancreatitis, that's something that we need to be monitoring for, is, that shortness of breath that develops because with ARDS, this has a very, very high risk of mortality if not treated. So let's talk about diagnosis. So diagnosis. So ARDS is going to be diagnosed by seeing bilateral lung infiltrates. In addition, this is not going to be cardiogenic pulmonary edema. So if they're fluid overloaded, they have heart failure, they develop this shortness of breath, you look on your chest x-ray, you see bilateral infiltrates, this is not pulmonary edema. This is not fluid related, this is inflammatory related. So it's not coming from a big oh, you're massively fluid overloaded. This is coming from an inflammatory cascade, to which fluid overload can worsen this, but this is all triggered by this inflammatory cascade that occurs. And lastly, the cause has to be within the last 7 days. So this is the acute issue that's going on. So if you have this overall issue that occurs and then, you know, months down the line, this isn't a chronic thing. This is an acute issue. So 7 days is our time frame. Okay, so let's start talking about treatment. I'm gonna clean my board here. So treatment of ARDS. The way I like to remember it is the P's for positive outcomes. So first P is going to be perfusion. You have to make sure they have a good blood pressure. If your lungs aren't receiving good blood flow, then the patient will remain hypoxic. So whether that is with pressors, fluid if you have to, but with ARDS typically we're trying to restrict fluids. Wet lungs are not happy lungs, so most likely you would be using, you know, your inotropes or your pressors in order to maintain appropriate blood flow and hemodynamics to the lungs. So perfusion is key. Another one is going to be positive pressure ventilation. So positive pressure ventilation, basically putting them on a vent, they're going to be getting PEEP with this. So PEEP is the pressure that remains in the lungs at the end of exhalation. So when the patient breathes out, PEEP is basically making sure that your lungs are still partially inflated, those alveoli are still open, so there can be proper gas exchange. If you don't have PEEP like we do, like I do right now on room air, those alveoli are collapsing. Because those alveoli are surrounded by all this fluid, and filled with fluid and inflammatory cytokines, all this junk, it's going to make it more difficult for there to be proper gas exchange, hence the refractory hypoxia. So the PEEP's going to allow these to remain open so that way there can be gas exchange. All right, so PEEP is great for ARDS. You need this in order to provide that gas exchange, or else you're just going to remain hypoxic. So positive pressure ventilation. Another one, if they're ventilated, is going to be protective lung ventilation. So with this, we're talking about these lungs are full of junk. They have poor compliance. So there's how stretchy that lung is, it's not good basically, because it's the lungs are sick, they're filled with fluid, they're filled with inflammatory cytokines. And so by doing protective lung ventilation, we're reducing the risk, which this patient's at high risk for, volume trauma and barotrauma. So we want decreased volume trauma and barotrauma. Oh, I can't spell, sorry. I'm like, goodness gracious. You'll learn, if you haven't already, that I can't talk and write at the same time, and I'm a horrible speller. As you can see already. So, to do this, what we're going to do is we're going to dose tidal volume to 4 to 6 millimeters per kg ideal body weight. This is not their actual body weight. So don't, it's my advice that you do not go look up what your ideal body weight is. It's pretty sad, but this is how we dose tidal volume. So we're not giving them large amounts of volume with each breath that they're taking on the ventilator. We're only giving them 4 to 6 mLs per kg ideal body weight. So this is going to end up causing lower volumes, and therefore the patient will develop some hypercapnia. That's okay. We are going for this permissive hypercapnic state. So perfusion is key, positive pressure ventilation is key, protective lung ventilation is key if you're doing this. Another thing we're thinking about is paralytics. Paralytics will improve outcomes with ARDS. The reason why is because when you develop this ARDS, you're in this massive respiratory failure state, and it's really hard to breathe. So what are you going to use when you're actively breathing is your intercostal muscles, your diaphragm, and these muscles use up a lot of oxygen and they produce a lot of CO2. So with the paralytics, what they're going to be doing is they're going to be reducing the amount of oxygen needs, they're going to be reducing the amount of CO2 production, and therefore then your hypoxia is getting better, or you're less hypoxic. So paralytics are key. The other good thing about paralytics is because they paralyze those muscles, you're going to have increased venous return. When you have positive pressure ventilation, a lot of PEEP, and you're in this ARDS, you're going to be basically, because of that increased thoracic pressure, you're reducing the amount of volume return to the heart, and therefore then you're having decreased preload and you're having some changes in contractility because of that increased pressure here in the chest. So when you give them these paralytics, don't be surprised if your perfusion is improved, because you're not squeezing down the heart with those muscles, is increasing venous return and therefore increasing cardiac output. So paralytics are great. So I'm going to erase this and let's talk about positions. That's our next P. So positioning. So obviously with these people, we want to be turning them. That's going to be mobilizing secretions, mobilizing that fluid out of the alveoli into the main airway and then out of the body, so that way we can get all that stuff out of their lungs. Now, so turning is a big thing, but also proning is very good for these patients, and it actually reduces mortality. And the reason why is because when I'm laying flat on my back, you have these lung zones basically. So you have your heart, right? And you have these lung zones. So you have zone 1, zone 2, and zone 3. Now, the back of your lungs, where a majority of this illness is occurring, is going to be weighed down by the heart. So you're actually getting reduced blood flow in these areas, and there's increased blood flow over here. But these parts aren't the problem. It's this back part that is. So whenever we prone, we're basically flipping all this. Your heart is going to be over here in zone 1. It frees up areas for zone 3, so that way there can be perfusion and oxygen exchange. So overall, proning is very, very good for these patients. We can prone manually. We can also prone with a rotoprone bed. Since I'm filming this around the time of COVID-19, with all the COVID-19 patients, we are manually proning them. So positioning is a big key factor. And then the last thing is prevention of complications. So this is going to be your DVT, your pressure injury. This is going to be your malnutrition. All these issues we want to try and prevent. Okay, so those are your P's for positive outcomes. And now the last thing I want to talk about is severity. And the way we measure the severity of ARDS is actually with what's called a PF ratio. So PF ratio is the ratio between our PaO2 on our ABG and our FiO2, okay? So let's do an example here. So let's say my patient is mechanically ventilated, maybe they're on a PEEP of 5, whatever, and they're getting an FiO2 of 80%, right? So FiO2 of 80%, that's 0.8, right? And then we get a blood gas, and their blood gas says that their PaO2 is 60, right? So on 80% PEEP of 5, their PaO2 is 60. PaO2 of 60 is not normal anyways, right? On room air, 21%, our PaO2 should be at least 80, you know? So this isn't a good thing here. So then what we're going to do is we will divide our PaO2 60 by 0.8, and that would equal 75. Okay, so this is your PF ratio. A PF ratio of 75 is severe ARDS, which correlates with about 42% mortality. Okay, so let's talk about the breakdown of these PF ratios and how bad is it, okay? So if you have a PF ratio and you have ARDS and your PF ratio is 200 to 300, you have a mild ARDS. If it is 100 to 200, you have a moderate ARDS. And at this range, if you have a PF ratio less than 150, you should prone, okay? Proning is the move here, okay? This is our trigger here. If your PF ratio is less than 100, then you have severe ARDS, okay? So that's your breakdown. As you have worsening ARDS, your mortality is increased, okay? So that's why we're doing all of these P's for positive outcomes. We're proning, we're paralyzing, we're putting them on the vent, we're going up on our PEEP. All these things are going to help heal the lungs, accelerate the healing process, and hopefully our patient does not develop any organ dysfunction. If they do, then we have to do those supportive measures. So they're hypoxic. We all know once you get hypoxic, you're going to change up your metabolism. The patient will then become acidotic because they're switching from aerobic to anaerobic metabolism. You produce more lactic acid, you develop a metabolic acidosis, and then if you're not compensating, then you develop a respiratory acidosis. So you have double acid-base imbalances. Once you get acidotic, your blood pressure is going to drop, your kidneys will fail, you're hypoxic, then you end up on dialysis. In addition, you're not perfusing maybe your liver, your bowel, you're going to develop a lot more issues. So skin failure, kidney failure, liver failure, GI failure, all these issues. So with ARDS, we really got to know what makes these things better. How do we measure if somebody's getting better or not? And that is basically a quick talk on ARDS. I didn't cover everything, but I did do this in just like a few minutes. So hopefully this helps you out. If you have any questions, please reach out to me, and I'll see you in the next video. Bye.